What are the major risk factors for developing coronary artery disease, and how do they contribute to the pathophysiology of the condition? Answer: coronary artery disease (CAD) is a major cause of morbidity and mortality globally and is primarily attributed to atherosclerosis, which leads to the narrowing of coronary arteries and reduced blood flow to the heart. Major risk factors for CAD include age, gender, family history, hypertension, hyperlipidemia, diabetes mellitus, smoking, obesity, and physical inactivity. Age and gender are non-modifiable risk factors. Men are generally at higher risk than premenopausal women, but this risk equalizes post-menopause. Family history suggests a genetic predisposition, as certain individuals may inherit traits that increase the likelihood of developing CAD. Hypertension increases the workload of the heart and can damage the arterial walls, promoting atherosclerosis. Similarly, hyperlipidemia, particularly elevated levels of low-density lipoprotein (LDL) cholesterol, contributes to plaque formation within arterial walls. Diabetes mellitus accelerates atherosclerosis due to increased levels of blood glucose, leading to endothelial dysfunction and inflammation. Lifestyle factors such as smoking and obesity further compound risk, as smoking introduces toxic substances that damage the endothelium, while obesity is linked to insulin resistance and metabolic syndrome. Physical inactivity contributes to obesity and its associated metabolic risks. Understanding these risk factors helps in risk stratification, prevention, and management strategies for patients, emphasizing the importance of lifestyle modifications, pharmacological interventions, and regular monitoring. Compare and contrast idiopathic pulmonary fibrosis and sarcoidosis in terms of clinical features, diagnostic evaluation, and management strategies. Answer: idiopathic pulmonary fibrosis (IPF) and sarcoidosis are two distinct interstitial lung diseases characterized by pulmonary inflammation and fibrosis, but they differ significantly in their clinical presentation, diagnostic evaluation, and management strategies. Clinical features: IPF typically presents with progressive dyspnea and a persistent dry cough, usually in older adults, and leads to respiratory failure over time. Patients may have crackling sounds, Velcro rails upon auscultation. In contrast, sarcoidosis often affects younger individuals and may present with a variety of systemic symptoms, including fever, fatigue, weight loss, and skin lesions, erythema nodosum. Patients may also experience ocular involvement and lymphadenopathy. Diagnostic evaluation. The diagnosis of IPF involves high-resolution computed tomography (HOT), which reveals a characteristic pattern of reticular opacities and honeycombing in the lungs. Lung biopsies are often performed to rule out other conditions. In contrast, sarcoidosis is diagnosed through clinical evaluation, imaging such as chest X-ray showing hilar lymphadenopathy, and tissue biopsy, which reveals non-K-setting granulomas. Serum angiotensin-converting enzyme ACE levels may be elevated in sarcoidosis but are not definitive. Management strategies. Management of IPF typically includes antifibrotic agents like pirfenidone or nintedanib, which slow disease progression, along with supportive measures like oxygen therapy and pulmonary rehabilitation. In advanced cases, lung transplantation may be necessary. Sarcoidosis often resolves spontaneously, so management focuses on monitoring. However, systemic corticosteroids are used for significant symptoms or complications. In summary, while both conditions affect lung function, their differences in clinical features, diagnostic evaluation, and management highlight the importance of accurate diagnosis and individualized treatment approaches. What are the hallmark symptoms of Crohn's disease, and how does its diagnosis differ from ulcerative colitis? Answer: Crohn's disease is a type of inflammatory bowel disease characterized by transmural inflammation that can affect any part of the gastrointestinal tract, whereas ulcerative colitis primarily involves the colon and rectum. The hallmark symptoms of Crohn's disease include abdominal pain, diarrhea, which may be bloody, weight loss, and fatigue. Patients may also experience extraintestinal manifestations such as joint pain, skin lesions, and eye inflammation. In contrast, ulcerative colitis typically presents with continuous mucosal inflammation, leading to bloody diarrhea, abdominal cramps, and urgency. While both conditions may present with overlapping symptoms, the pattern of involvement and associated complications differ significantly. Diagnostic approach. The diagnosis of Crohn's disease relies on a combination of clinical evaluation, laboratory tests, imaging studies, and endoscopic procedures. Physicians may order blood tests to assess for anemia or inflammation and stool tests to rule out infections. An imaging study such as a CT scan or MRI can help visualize bowel involvement, while endoscopy, colonoscopy, allows for direct visualization and biopsy of the intestinal mucosa. Biopsies in Crohn's disease may show non-castrating granulomas, which are indicative of the condition. Ulcerative colitis is diagnosed similarly but focuses on the colon, often demonstrating a pattern of continuous inflammation in the colon during endoscopy. Biopsy results typically reveal mucosal inflammation and cryptabscesses. In summary, Crohn's disease and ulcerative colitis present with distinct symptoms and patterns of gastrointestinal involvement, necessitating specific diagnostic criteria for accurate diagnosis and management. What are the key differences in clinical presentation and laboratory findings between Cushing's syndrome and Addison's disease? Answer: Cushing's syndrome and Addison's disease represent opposing states of adrenal hormone imbalance, specifically cortisol. Cushing's syndrome, often caused by excess cortisol production due to pituitary adenomas or adrenal tumors, typically presents with symptoms such as weight gain, especially around the abdomen, facial rounding, moon phases, easy bruising, hypertension, glucose intolerance, and skin changes. Strive. Patients may also experience mood swings and decreased libido. Laboratory findings often include elevated serum cortisol levels, especially following a dexamethasone suppression test, which assesses the feedback mechanism of cortisol production. Conversely, Addison's disease results from insufficient cortisol production, often due to autoimmune destruction of the adrenal glands. Clinical features include chronic fatigue, muscle weakness, weight loss, hyperpigmentation of the skin due to increased ACTH levels, hypotension, and salt craving. Addisonian crisis can occur, characterized by severe hypotension and electrolyte imbalances, requiring immediate treatment. Laboratory evaluations typically show low serum cortisol levels, elevated ACTH, and possible hyponatremia and hypokalemia. The management strategies differ considerably. Cushing's syndrome often involves surgical removal of the tumor or pharmacological treatment to reduce cortisol levels, while Addison's disease is managed through lifelong glucocorticoid hydrocortisone and mineralocorticoid fludrocortisone replacement therapy. In conclusion, understanding the distinct clinical presentations and laboratory findings is crucial for the diagnosis and treatment of these two contrasting endocrine disorders. How do iron deficiency anemia and B deficiency anemia differ in terms of clinical features and diagnostic workup? Answer: Iron deficiency anemia (IDA) and vitamin B deficiency anemia, pernicious anemia, are two common types of macrocytic anemia characterized by distinct etiologies, clinical features, and laboratory findings. Clinical features: IDA typically presents with symptoms such as fatigue, weakness, pallor, shortness of breath, and possibly pica, the craving for non-nutritive substances. In severe cases, patients may exhibit brittle nails or hair loss. In contrast, B deficiency can cause neurological symptoms including paresthesia, tingling in the extremities, balance problems, and cognitive disturbances due to its role in nerve health and function. Diagnostic workup. In terms of laboratory evaluation, IDA is characterized by low hemoglobin levels, low serum ferritin, low serum iron, and high total iron binding capacity (TIC), indicating depleted iron stores. A peripheral blood smear may show microcytic, hypochromic red blood cells. A deficiency anemia, however, is identified through low serum B levels, high mean corpuscular volume (MCV), indicating macrocytosis, and potentially elevated methylmalonic acid (MMA) and homocysteine levels. A peripheral smear may reveal macrocytic red blood cells and possible hypersegmented neutrophils. In summary, while both types of anemia present with fatigue and weakness, the presence of neurological symptoms, distinctive laboratory findings, and the underlying causes, iron deficiency versus B deficiency, play critical roles in their diagnosis and management. What are the common clinical presentations of a urinary tract infection and how is it diagnosed and treated? Answer: Urinary tract infections, UTIs, are common infectious conditions, especially among women, characterized by the presence of pathogenic microorganisms in the urinary tract. Common clinical presentations include dysuria, painful urination, urgency, the need to urinate frequently, increased frequency of urination, suprapubic pain, and in some cases, hematuria, blood in the urine. Patients may also experience systemic symptoms such as fever and chills if the infection progresses to the kidneys, pyelonephritis. Diagnostic evaluation. The diagnosis of a UTI typically begins with a thorough history and physical examination. A urinalysis is performed to identify the presence of leukocytes, nitrites, and bacteria in the urine. Urine culture is often obtained to confirm the diagnosis and identify the causative organism, guiding appropriate antibiotic therapy. In cases of recurrent infections or complications, imaging studies such as renal ultrasound or CT scans may be employed to assess for underlying anatomical abnormalities. Treatment. Treatment of UT primarily involves the use of antibiotics. The choice of antibiotic depends on the specific bacteria identified and local resistance patterns. Common first-line agents include nitrofurantoin, trimethoprim sulfamethoxazole, and fosfomycin. The duration of treatment may vary, typically ranging from 3 to 7 days for uncomplicated UTIs, while complicated UTIs may require longer courses. In addition to antibiotic therapy, increased fluid intake and analgesics may help alleviate symptoms. Preventive measures, such as proper hygiene practices, post-coital voiding, and the use of cranberry products may also reduce the risk of recurrent infections. Describe the different types of strokes and the role of thrombolytic therapy in the acute management of ischemic stroke. Answer: strokes can be classified into two primary types: ischemic and hemorrhagic. Ischemic strokes occur when blood flow to the brain is obstructed, often due to a blood clot or embolism. They account for approximately 87% of all strokes. Hemorrhagic strokes result from the rupture of a blood vessel in the brain, leading to bleeding and increased intracranial pressure. These can be further classified into intracerebral hemorrhage and subarachnoid hemorrhage. Types of ischemic strokes. Thrombotic stroke occurs when a blood clot thrombus forms in an artery supplying blood to the brain, typically due to atherosclerosis. Embolic stroke occurs when a clot or debris forms away from the brain, often in the heart, and travels through the bloodstream to lodge in a narrow brain artery. Thrombolytic therapy. Thrombolytic therapy is a critical intervention for patients with ischemic stroke, as it can significantly improve outcomes if administered promptly. The most commonly used thrombolytic agent is tissue plasminogen activator (EPA), which works by dissolving the clot and restoring blood flow to the affected area of the brain. For optimal results, TPA must be administered within 3 to 4.5 hours of symptom onset. Early recognition of stroke symptoms using the FAST method: face drooping, arm weakness, speech difficulty, time to call emergency services, is crucial for timely treatment. While thrombolytic therapy can be highly effective, it is not suitable for all patients, particularly those with contraindications such as active bleeding or recent surgery. After thrombolysis, further management may include antiplatelet therapy, rehabilitation, and secondary stroke prevention strategies. In summary, understanding the types of strokes and the role of thrombolytic therapy is vital for improving patient outcomes and reducing disability associated with strokes. What are the pathophysiological mechanisms behind rheumatoid arthritis, and how do they influence treatment options? Answer: rheumatoid arthritis is a chronic autoimmune inflammatory disorder that primarily affects the joints but can also have systemic manifestations. The pathophysiology of RA involves a complex interplay of genetic predisposition, environmental triggers, and immune system dysfunction. In RA, the immune system mistakenly attacks the synovial tissue, the lining of the joints, leading to chronic inflammation. This inflammatory process is mediated by various immune cells, including T cells, B cells, and macrophages, which infiltrate the synovium. The release of pro-inflammatory cytokines, such as tumor necrosis factor alpha and interleukins, contributes to synovitis, leading to the destruction of cartilage and bone over time. As inflammation progresses, the formation of pannus, abnormal granulation tissue, occurs, eroding cartilage and bone, resulting in joint deformities and functional impairment. Systemic manifestations may include fatigue, malaise, and involvement of other organ systems such as the lungs, skin, and heart. Treatment options. The management of RA focuses on controlling inflammation, relieving symptoms, and preventing joint damage. Nonsteroidal anti-inflammatory drugs, NSAIDs, are commonly used to manage pain and inflammation. Disease-modifying antiemetic drugs, DMARDs, such as methotrexate, are the cornerstone of treatment to slow disease progression and reduce long-term joint damage. Biologic agents that target specific pathways in the inflammatory process, e.g., TNF inhibitors, have also become important treatment options for patients with moderate to severe RA. In addition to pharmacotherapy, a multidisciplinary approach including physical therapy, occupational therapy, and lifestyle modifications, such as exercise and weight management, plays a crucial role in managing RA. Regular monitoring and adjustments in treatment are essential for achieving optimal control of the disease and maintaining quality of life. In conclusion, understanding the pathophysiological mechanisms behind rheumatoid arthritis guides the development of targeted therapies, allowing for a more personalized approach to treatment. Describe the types of heart failure and the significance of the New York Heart Association (NYHA) classification system in managing patients with heart failure. Answer: heart failure, HF, can be categorized into two primary types: systolic heart failure, HFrEF, and diastolic heart failure, HSPEF. Systolic heart failure, HFrEF. This type is characterized by a reduced ejection fraction equals 50%. The New York Heart Association (NYHA) classification system is crucial for assessing the severity of heart failure and guiding treatment decisions. It divides patients into four classes based on their functional capacity and symptoms. Class I: no limitation in physical activity. Class 2: light limitation and comfortable at rest, but ordinary physical activity causes symptoms. Class through marked limitation and comfortable at rest, but less than ordinary activity causes symptoms. Class unable to carry on any physical activity without discomfort if symptoms may occur at rest. The NYHA classification helps clinicians tailor treatment strategies. For instance, patients in Class I may benefit from lifestyle modifications and monitoring, while those in Class I or IV may require more aggressive pharmacotherapy, potential hospitalization, and evaluation for advanced therapies like device therapy or heart transplant. Regular assessment using this classification aids in tracking disease progression and treatment response. What are the common diagnostic criteria used to evaluate a patient suspected of having obstructive sleep apnea? Answer: obstructive sleep apnea (OSA) is a common disorder characterized by repeated episodes of partial or complete obstruction of the upper airway during sleep, leading to disrupted sleep and oxygen desaturation. Diagnosing OSA typically involves a combination of clinical assessment, questionnaires, and objective testing. Common diagnostic criteria: clinical symptoms. The evaluation starts with identifying common symptoms such as loud snoring, witnessed apneas during sleep, excessive daytime sleepiness, fatigue, and difficulty concentrating. The Epworth Sleepiness Scale (S) is often utilized to quantify daytime sleepiness. Physical examination. A thorough physical examination can reveal obesity, a large neck circumference, and oropharyngeal abnormalities, e.g., enlarged tonsils, a large tongue, polysomnography (PSG). The gold standard for diagnosing OSA is an overnight polysomnography, which records brain waves, oxygen levels, heart rate, and breathing patterns during sleep. Key findings in OSA include apnea-hypopnea index (AHI). The number of apneas and hypopneas per hour of sleep, HI5, is considered diagnostic for OSA, with varying severity levels: mild, 5-1-5 moderate, 1-5-3-0 severe. 30. Home sleep apnea testing (HSAT). In selected cases, HSAT can be utilized as a convenient alternative to PSG. It typically includes simpler monitoring of airflow, respiratory effort, and oxygen saturation, but is less comprehensive than PSG. Accurate diagnosis of OSA is essential as it is associated with significant comorbidities including cardiovascular disease, hypertension, and impaired cognitive function. Effective diagnosis leads to appropriate management strategies such as lifestyle changes, continuous positive airway pressure, CPAP, therapy, or surgical interventions. Discuss the management options available for portal hypertension secondary to liver cirrhosis, including both medical and surgical approaches. Answer: portal hypertension, a common complication of liver cirrhosis, arises from increased resistance to blood flow through the liver. Management focuses on alleviating symptoms and preventing complications such as variceal bleeding in ascites. Medical management. Non-selective beta blockers. Medications such as propranolol and nadolol are commonly used to reduce portal pressure by decreasing cardiac output and splanchnic blood flow, effectively lowering the risk of variceal hemorrhage. Diuretics. For patients with ascites, diuretics like Spire, nalactone, and furosemide help manage fluid retention. Monitoring of electrolytes is essential, as these medications can cause hyponatremia or renal impairment. Endoscopic therapy. For patients with variceal bleeding, urgent endoscopy is performed for band ligation or sclerotherapy to control the bleeding. This procedure is often followed by prophylactic treatment with beta blockers. Surgical management. Transjugular intrahepatic portosystemic shunt (TIPS). This procedure creates a shunt between the portal and hepatic veins, reducing portal pressure. TIPS is effective for treating refractory ascites and preventing variceal bleeding, though it carries risks such as hepatic encephalopathy. Surgical shunt procedures. In cases where TIPS is not appropriate, surgical options include distal splenoidal Warren shunt or portocaval shunt, though these procedures are less commonly performed today. Liver transplantation. For patients with end-stage liver disease and decompensated cirrhosis, liver transplantation is the definitive treatment that resolves portal hypertension. The selection criteria include the severity of liver dysfunction, associated comorbidities, and psychosocial factors. Management of portal hypertension requires a multidisciplinary approach, and regular monitoring is crucial for optimizing therapy and preventing complications. Define metabolic syndrome and discuss the implications of each component in terms of cardiovascular risk. Answer: metabolic syndrome is a cluster of metabolic abnormalities that increase an individual's risk of cardiovascular disease (CVD) and type 2 diabetes. The criteria for diagnosing metabolic syndrome typically include the presence of at least three of the following components: abdominal obesity, defined by waist circumference equals 102 centimeters in men equals 88 centimeters in women. Abdominal fat is particularly harmful as it is associated with increased insulin resistance and inflammation. Hypoglycemia. This can be manifested as fasting blood glucose levels equals 100 mdl, a diagnosis of type 2 diabetes. Elevated glucose levels contribute to endothelial dysfunction and promote atherogenesis. Hypertension, defined as blood pressure equals 130/85 millimeters Hg, or use of antihypertensive medication. High blood pressure increases the workload on the heart and arteries, leading to heart failure and stroke risk. Dyslipidemia, characterized by elevated triglycerides equals 100 mdl and low high-density lipoprotein HDL cholesterol 4 mdl in men and 5 mdl in women. This lipid profile is associated with increased atherosclerotic plaque formation. Insulin resistance, often assessed via fasting insulin levels or calculated using the homeostasis model assessment (HOMA). Insulin resistance is a key driver of several metabolic abnormalities, leading to further cardiovascular risk. The implications of metabolic syndrome are profound, as individuals with this condition face a significantly higher risk of developing cardiovascular events such as myocardial infarction and stroke. The presence of multiple risk factors necessitates a comprehensive approach to management, including lifestyle modifications, diet and exercise, pharmacotherapy, antihypertensives, statins, glucose-lowering agents, and regular monitoring for cardiovascular health. Explain the management strategies for a patient diagnosed with hemophilia and the importance of factor replacement therapy. Answer: hemophilia is a genetic bleeding disorder characterized by a deficiency in specific clotting factors, most commonly factor VII hemophilia A or factor IX hemophilia B. The management of hemophilia focuses on preventing and treating bleeding episodes, with factor replacement therapy being the cornerstone of treatment. Management strategies. Factor replacement therapy. The primary treatment for hemophilia involves administering clotting factor concentrates. These can be derived from human plasma, plasma-derived, or produced using recombinant DNA technology, recombinant factors. The choice depends on the patient's needs, availability, and preference. Prophylactic factor replacement, administered regularly, can prevent spontaneous bleeding episodes and is particularly important in severe hemophilia. On-demand treatment. For patients with mild to moderate hemophilia, treatment may be provided on demand, meaning factor concentrates are given only in response to bleeding episodes. Timely administration can significantly improve outcomes and reduce complications. Management of complications. Patients are at risk for joint damage due to repeated bleeding into joints, hemarthrosis. Early recognition and treatment of bleeds are crucial. Physical therapy, along with appropriate pain management, can help preserve joint function. Education and monitoring. Patient education about self-infusion techniques, recognition of bleeding episodes, and the importance of adherence to prophylaxis is vital. Regular monitoring of factor levels and joint health through physical examinations and imaging studies helps to tailor treatment plans. Emerging therapies, newer treatments including gene therapy and non-factor replacement therapies, e.g. emicizumab for hemophilia A, show promise in improving care for hemophilia patients and may alter the landscape of management in the future. Overall, factor replacement therapy is critical for managing hemophilia as it directly addresses the underlying deficiency and significantly reduces morbidity associated with bleeding episodes. Discuss the principles of antimicrobial stewardship and its role in combating antibiotic resistance. Answer: antimicrobial stewardship refers to a set of coordinated strategies aimed at improving and measuring the appropriate use of antimicrobials, antibiotics, antivirals, antifungals, and antiparasitics to enhance patient outcomes, reduce microbial resistance, and decrease the spread of infections caused by multi-drug resistant organisms. Principles of antimicrobial stewardship: appropriate prescribing, ensuring that the right antimicrobial is selected for the right duration, at the right dose, and for the right patient. This includes using culture and sensitivity results to guide therapy and avoiding broad-spectrum antibiotics when narrow-spectrum agents would be effective. Optimizing therapy, regularly reviewing ongoing antimicrobial therapy to determine if it can be de-escalated or discontinued based on clinical response and laboratory findings. This approach minimizes unnecessary exposure to antibiotics. Education and awareness. providing education to healthcare providers and patients about the risks associated with inappropriate antimicrobial use, including side effects and the potential for developing resistance, infection prevention and control, implementing measures to reduce the risk of infections, thereby decreasing the need for antibiotics. This includes vaccination, proper hand hygiene, and the use of personal protective equipment, data monitoring and feedback, collecting and analyzing data on antimicrobial use and resistance patterns within healthcare settings. Providing feedback to prescribing clinicians on their prescribing patterns promotes accountability and improvement. The role of antimicrobial stewardship in combating antibiotic resistance is crucial, with increasing rates of resistance, particularly to common pathogens such as methicillin-resistant Staphylococcus aureus (MRSA) and multi-drug-resistant gram-negative bacteria. Effective stewardship programs are essential for preserving the efficacy of existing antibiotics. By promoting the judicious use of antimicrobials, stewardship initiatives aim to extend the lifespan of current antibiotics, improve patient care, and ultimately save lives. What are the common types of seizures associated with epilepsy, and how are they classified and managed? Answer: epilepsy is characterized by recurrent seizures resulting from abnormal electrical activity in the brain. Seizures can be classified into several categories based on their clinical presentation and electroencephalogram EEG findings. Common types of seizures: focal seizures. These originate in a specific area of the brain and can be subdivided into focal onset aware seizures. Patients remain aware during the seizure. Focal onset impaired awareness seizures. Patients experience altered consciousness during the event. Generalized seizures. These involve both hemispheres of the brain from the onset and include tonic-clonic seizures, characterized by a loss of consciousness and violent muscle contractions. Absence seizures. Brief episodes of staring and unresponsiveness often occurring in children. Myoclonic seizures. Sudden, brief jerking movements. Unknown onset seizures. Seizures where the onset is not classified as focal or generalized. Classification. The International League Against Epilepsy (ILE) provides a comprehensive classification system based on the seizure type, its onset, and the patient's awareness level. This classification helps clinicians determine the appropriate management strategies. Management. Pharmacotherapy. The first-line treatment for epilepsy is antiepileptic drugs (AEDs). The choice of AED depends on the seizure type, patient age, comorbid conditions, and side effect profiles. Common AEDs include levetiracetam, lamotrigine, and valproate. Surgery. For patients with refractory epilepsy who do not respond to medications, surgical interventions such as resective surgery may be considered to remove the seizure focus. Lifestyle modifications. Patients are encouraged to avoid seizure triggers such as stress, sleep deprivation, and alcohol. Safety measures such as wearing a medical alert bracelet and avoiding dangerous activities, e.g. swimming alone, are also essential. Patient education. Educating patients and caregivers about seizure recognition management and first aid measures is crucial for safety and confidence. Differentiate between the management strategies for acute gout attacks versus chronic gout management. Answer: gout is a type of inflammatory arthritis caused by the accumulation of uric acid crystals in the joints. Management strategies differ significantly between acute gout attacks and chronic gout management. Acute gout attack management. Non-steroidal anti-inflammatory drugs, NSAIDs, NSAIDs such as indomethacin, naproxen, or ibuprofen are commonly prescribed to reduce inflammation and pain. Treatment should start as soon as the attack begins. Colchicine. This medication is effective in treating acute gout flares, particularly if administered early in the attack. It works by inhibiting inflammation and is an alternative to NSAIDs. Corticosteroids. For patients who cannot tolerate NSAIDs or colchicine, corticosteroids, e.g. prednisone, can be used to reduce inflammation and pain. Rest and ice. Patients are advised to rest the affected joint and apply ice to reduce swelling. Chronic gout management. Urate-lowering therapy, ULT. The primary goal is to lower serum uric acid levels to prevent future attacks. Allopurinol is commonly used to inhibit uric acid production, while febuxostat is another option for patients who are intolerant to allopurinol. Lifestyle modifications. Patients are encouraged to make dietary changes such as reducing purine intake found in red meats and seafood, avoiding alcohol, and maintaining adequate hydration. Weight loss may also be beneficial. Regular monitoring. Serum uric acid levels should be monitored regularly to ensure they remain below the target level, usually SIMDDL. Patient education. Educating patients about the chronic nature of gout, the importance of adherence to ULT, and recognizing early symptoms of flare-ups can help prevent complications. Adjunctive medications. In some cases, medications such as Promacid, which increases uric acid excretion, may be considered based on individual patient factors. What are the key symptoms and diagnostic criteria for major depressive disorder, and how do they impact treatment options? Answer. Major depressive disorder, MDD, is a common psychiatric condition characterized by persistent feelings of sadness and loss of interest or pleasure in activities once enjoyed. The diagnosis is primarily based on clinical criteria established by the Diagnostic and Statistical Manual of Mental Disorders, DSM-5. Key symptoms. The diagnosis of MDD requires at least 5 of the following symptoms to be present for at least 2 weeks, with at least one of the symptoms being either depressed mood or loss of interest, pleasure, depressed mood, feeling sad, empty, or hopeless most of the day, anhedonia, markedly diminished interest or pleasure in most activities, weight changes, significant weight loss or gain, or changes in appetite, sleep disturbances, insomnia or hypersomnia nearly every day, psychomotor agitation or retardation, observable restlessness or slowing down, fatigue, loss of energy or increased fatigue, feelings of worthlessness or excessive guilt, often unrealistic self-blame, cognitive impairments, difficulty concentrating, making decisions, or thinking clearly. Diagnostic criteria. The DSM-5 criteria include the presence of these symptoms and their significant impact on social, occupational, or other important areas of functioning. Furthermore, symptoms should not be attributable to another medical condition or substance use. Impact on treatment options. The diagnosis of MDD directly influences treatment decisions. First-line treatments typically include psychotherapy. Cognitive behavioral therapy (CBT) or interpersonal therapy can be effective, especially in mild to moderate cases. Pharmacotherapy. Antidepressants, such as selective serotonin reuptake inhibitors (SRIs) or serotonin norepinephrine reuptake inhibitors (SNRIs), are often prescribed for moderate to severe MDD. Combination therapy. For patients with more severe or treatment-resistant depression, combining psychotherapy and medication may be more effective. Other interventions. Options such as transcranial magnetic stimulation (TMS) or electroconvulsive therapy (ECT) may be considered in treatment-resistant cases. Discuss the clinical features of bipolar disorder and the importance of mood stabilizers in its management. Answer. Bipolar disorder is a mood disorder characterized by significant fluctuations in mood, energy, and activity levels, typically involving episodes of mania, hypomania, and depression. Clinical features. Manic episodes. During mania, individuals experience an elevated or irritable mood lasting at least 1 week. Symptoms include increased energy, decreased need for sleep, grandiosity, racing thoughts, distractibility, and engagement in high-risk activities, e.g., spending sprees, unprotected sex. Hypomanic episodes. Similar to manic episodes but less severe and shorter in duration, lasting at least 4 consecutive days. It do not cause significant impairment in social or occupational functioning. Depressive episodes. These episodes resemble major depressive disorder, featuring low mood, anhedonia, fatigue, sleep disturbances, and feelings of worthlessness or guilt. Depressive episodes often outnumber manic episodes. Mixed episodes. These involve symptoms of both mania and depression occurring simultaneously, leading to increased irritability and significant functional impairment. Importance of mood stabilizers. Mood stabilizers are the cornerstone of treatment for bipolar disorder. Their primary goals are to prevent recurrence by stabilizing mood. These medications help prevent the cyclical nature of the disorder, reducing the frequency and intensity of manic and depressive episodes. Reduce symptoms. Mood stabilizers effectively alleviate symptoms during acute manic or hypomanic episodes, contributing to better overall functioning. Minimize side effects. Compared to other treatment options, mood stabilizers, e.g., lithium valproate, lamotrigine, are often better tolerated, reducing the risk of adverse effects commonly associated with antipsychotics. Psychosocial benefits. Consistent use of mood stabilizers enhances treatment adherence and encourages patients to engage in therapy and lifestyle modifications, contributing to improved long-term outcomes. What lifestyle modifications should be recommended for patients diagnosed with hypertension? Answer. Recommended lifestyle modifications for patients diagnosed with hypertension include diet. Adopt the DASH diet, which emphasizes fruits, vegetables, whole grains, lean proteins, and low-fat dairy while reducing sodium intake to less than 2,300 mg per day, ideally aiming for 1,500 mg. Physical activity. Encourage at least 150 minutes of moderate intensity aerobic exercise each week, such as brisk walking or cycling. Weight management. Encourage weight loss if the patient is overweight or obese, as even a 5.10% reduction in body weight can significantly lower blood pressure. Limit alcohol. Advise moderation in alcohol consumption. No more than 1 drink per day for women and 2 for men. Tobacco cessation. Strongly advise quitting smoking as it exacerbates hypertension and overall cardiovascular risk. Stress management. Discuss techniques for managing stress, such as mindfulness, meditation, or relaxation exercises. What are the current recommendations for prostate cancer screening in average risk men? Answer: current recommendations for prostate cancer screening in average risk men include: age to start. Men aged 55 to 69 should discuss the potential benefits and risks of prostate-specific antigen assay testing with their healthcare provider. Shared decision-making. The decision to screen should be based on individual preferences, health status, and values, with an emphasis on informed consent. Frequency. If screening is initiated, PSA testing may be performed every 1-2 years depending on baseline levels and risk factors. Men over 70. Routine screening is not recommended for men over 70 years or those with a life expectancy of less than 1015 years, as the risks of screening may outweigh the benefits. High-risk groups: men with a family history of prostate cancer, African American men, and those with BRCA or EA mutations should begin discussions about screening earlier, typically around age 4045. What are the recommendations for screening for depression in adults? Answer: recommendations for screening for depression in adults include routine screening. The USPSTF recommends screening for depression in adults, including pregnant and postpartum women, in primary care settings where appropriate systems are in place for diagnosis, treatment, and follow-up. Frequency. Screening should occur annually or as clinically indicated based on risk factors or symptoms. Screening tools. Utilize standardized screening instruments such as the Patient Health Questionnaire 9, PHQ-9, or the Beck Depression Inventory to assess the presence and severity of depressive symptoms. Follow-up. If screening results are positive, providers should conduct a thorough clinical evaluation to confirm the diagnosis and discuss treatment options, including psychotherapy and pharmacotherapy. Referral. Consider referral to mental health professionals for patients with moderate to severe depression or those not responding to initial treatment. What health maintenance recommendations should be provided to elderly patients aged 65 and older? Answer: health maintenance recommendations for elderly patients aged 65 and older include comprehensive geriatric assessment, conduct regular assessments to evaluate physical, psychological, and social functioning, including assessments for frailty, cognitive function, and mobility. Vaccinations. Ensure vaccinations are up to date, including influenza, pneumococcal shingles, and tetanus. Chronic disease management. Optimize management of chronic conditions such as diabetes, hypertension, and heart disease through regular monitoring and medication adherence. Screening. Screen for conditions such as osteoporosis, depression, and cancer, breast, cervical, prostate, and colorectal, according to established guidelines, with an emphasis on shared decision-making. Nutrition and hydration. Address nutritional needs, ensuring adequate protein and caloric intake, and promote proper hydration to prevent dehydration. Physical activity. Encourage regular physical activity tailored to individual abilities to maintain mobility, strength, and balance. A 30-year-old woman presents with joint pain, morning stiffness lasting over an hour, and a rash on her cheeks. Laboratory tests reveal a positive ANA and anti-DNA antibodies. What is the most likely diagnosis and what management strategies should be considered? Answer: the clinical presentation, along with positive ANA and DNA antibodies, is suggestive of systemic lupus erythematosus, SLE. Management strategies should include non-pharmacological management, encourage lifestyle modifications, including rest, regular exercise, and sun protection to prevent skin rashes. Pharmacotherapy, NSAIDs, for pain relief and inflammation control. Antimalarials, e.g. hydroxychloroquine. These are often used as a first-line treatment for skin and joint symptoms. Corticosteroids. Consider for moderate to severe disease flares, managing doses based on symptom control and disease activity. Immunosuppressants. For patients with severe manifestations or organ involvement, agents like azathioprine or mycophenolate mofetil may be warranted. Regular follow-up is essential to monitor disease activity and adjust the management plan accordingly. A 68-year-old man suddenly develops weakness in his right arm and difficulty speaking. What steps should be taken for the immediate assessment and management of a suspected stroke? Answer: in a patient with suspected stroke, immediate assessment and management should follow these steps. Rapid assessment. Use the FAST acronym. Face drooping, ask the patient to smile. Arm weakness, ask the patient to raise both arms. Speech difficulty, ask the patient to repeat a simple phrase. Time to call emergency services. Emergency response. Call for emergency medical services intermediately to ensure rapid transport to a stroke center. Pre-hospital considerations. Ensure the patient remains calm and monitor vital signs during transport. Note the time of symptom onset for treatment decisions. Hospital evaluation. Upon arrival, perform a rapid neurological exam and obtain non-contrast CT imaging of the head to rule out hemorrhagic stroke management. If ischemic stroke is confirmed and the patient presents within the treatment window, typically within 4.5 hours, consider intravenous thrombolysis (GEPA) as appropriate. Timely intervention is crucial to minimize neurological damage and improve outcomes. Question 8. Pulmonary medicine, asthma management. An 80-year-old woman is taking multiple medications for hypertension, diabetes, and osteoarthritis. She presents with confusion and increased falls. What steps should be taken to assess and manage her polypharmacy? Answer. In an elderly patient presenting with confusion and increased falls, a thorough assessment of polypharmacy is essential. Medication review. Conduct a comprehensive medication review including prescription medications, over-the-counter drugs, and supplements. Identify potential drug-drug interactions and medications that may contribute to cognitive impairment or falls. Assessment tools. Utilize tools such as the Beers criteria to evaluate the appropriateness of medications in older adults and to identify potentially inappropriate medications. PIMS. The prescribing. Work collaboratively with the patient and caregivers to prescribe unnecessary medications, especially those that have a high risk of adverse effects or are no longer indicated. Education and support. Educate the patient and family members about the importance of adherence, potential side effects, and safe medication practices. Follow-up and monitoring. Schedule regular follow-up visits to monitor the patient's cognitive status, fall risk, and overall health after medication adjustments. What are the key components of effective health communication in patient care? Answer. Effective health communication is vital for ensuring that patients understand their conditions and treatment options. Key components include clarity. Information should be presented in simple, jargon-free language to enhance understanding. Empathy. Physicians should express empathy and active listening, validating patients' feelings and concerns. Cultural sensitivity. Communication should respect cultural differences, tailoring messages to fit patients' backgrounds and beliefs. Use of visual aids. Incorporating diagrams, charts, or models can help convey complex information more effectively. Encouraging questions. Physicians should foster an environment where patients feel comfortable asking questions and expressing doubts. Teach back method. Asking patients to repeat back information can confirm understanding and clarify any misunderstandings. Consistent messaging. Ensure that all healthcare team members communicate consistent information to avoid confusion. How does social determinants of health impact patient outcomes? Answer. Social determinants of health (ESTO) significantly influence patient outcomes by affecting access to care, health behaviors, and overall well-being. Key impacts include access to resources. Factors like income, education, and employment can determine access to healthcare services and health insurance. Health literacy. Lower health literacy can lead to misunderstandings about health conditions and treatment options, resulting in poorer health outcomes. Living conditions. Poor housing, unsafe neighborhoods, and environmental hazards can increase the risk of health problems. Social support. Strong social networks can promote better health behaviors and provide emotional support, while social isolation can lead to worse health outcomes. Nutrition. Access to healthy food options can affect dietary choices and overall health, influencing conditions like obesity and diabetes. Transportation. Limited transportation options can hinder access to medical appointments and essential services. Work environment. Occupational hazards and stress levels can impact physical and mental health. What role does technology play in modern healthcare delivery? Answer. Technology has transformed healthcare delivery in numerous ways, enhancing efficiency, accessibility, and patient outcomes. Key roles include telemedicine, facilitates remote consultations, increasing access to care for patients in rural or underserved areas. Electronic health records (EHRs) streamlines patient information management, improving data sharing and continuity of care. Health apps encourages self-management of health conditions through reminders, educational resources, and tracking tools. Wearable devices monitors health metrics like heart rate and activity levels, empowering patients to take charge of their health. Artificial intelligence (AI) assists in diagnosing conditions, predicting patient outcomes, and personalizing treatment plans based on data analysis. Robotic surgery enhances precision in surgical procedures, potentially reducing recovery times and complications. Big data analytics utilizes large datasets to identify trends, improve public health strategies, and enhance clinical decision-making. Patient portals provides patients with access to their health information, lab results, and communication with healthcare providers. What are the ethical implications of genetic testing in healthcare? Answer: genetic testing presents several ethical implications that healthcare providers must navigate, including informed consent, ensuring patients understand the purpose, risks, and potential outcomes of genetic testing before consenting; privacy and confidentiality, safeguarding sensitive genetic information from unauthorized access and potential discrimination; discrimination risks, concerns about genetic information being used to discriminate in employment or insurance coverage; psychological impact, consideration of the emotional consequences for patients receiving potentially life-altering genetic information; familial implications, the impact of genetic testing results on family members who may also be affected by hereditary conditions; equity and access, addressing disparities in access to genetic testing and counseling, particularly among underserved populations; clinical utility, evaluating the clinical significance of genetic testing results and their implications for patient care and treatment options. What strategies can healthcare organizations use to reduce health disparities among different populations? Answer: healthcare organizations can adopt several strategies to reduce health disparities, including cultural competency training, providing education to healthcare staff on cultural awareness and sensitivity to better serve diverse populations; community outreach programs, engaging with underserved communities to raise awareness of available health services and resources; access improvement initiatives, implementing programs to improve access to care, such as transportation services or telehealth options for remote areas; data collection and analysis, gathering and analyzing demographic data to identify and address specific health disparities within populations; language services, offering translation and interpretation services to ensure effective communication with non-English speaking patients; patient navigation programs, implementing programs to assist patients in navigating the healthcare system, making appointments, and understanding their care; partnerships with community organizations, collaborating with local organizations to address social determinants of health affecting marginalized groups;